I am live. All right, guys. Cheers. I'm going to sit here and enjoy my hazelnut decaf while I wait for you guys to jump on board. If you are watching the replay, if you could put in replay in the comment section so I can just kind of helps me keep track of who's watching the replay and who's watching live. And also that helps me find any questions that you might ask if you're watching the replay. All right, going to wait for a minute or two for everyone to jump on board. As always, guys, as you come on board, give me a shout out. Let me know who you are, where you're from, what's in your coffee mug or your flask this evening, whatever you got going on. And also, those of you who jumping on, just let me know if you can hear me okay. As always, I always like to double check my audio because it sometimes like to play tricks on me. Harsh, how you doing, man? Can you hear me okay, Harsh? Okay, Mark S. Awesome. Okay, you guys can hear me. I never know, guys. This is a beautiful microphone system that my team got for me for Christmas, and I really enjoyed it. But you know me. I have that magic touch sometimes. Hey, Ashley, got your sweet tea. Cheers to you. You're certainly getting into the weather where you're going to be able to really enjoy that sweet tea. Debbie, good to see you. Harsh, man, Harsh, I got to give you a shout out yesterday. You joined in on the Vital Fit webinar. And you mentioned that you lost quite a bit of weight, Harsh, and doing your exercises and everything. So I'm proud of you, man. Props to you. Kay, what's going on? Alaska and drinking her water. Okay, I hope it warms up just a little bit more for you so you can start doing your hiking with all the tips that you got from Greg last night. So last night, guys, I was doing a webinar that was hosted by Vital Fit. It's that skincare company that I absolutely love so much because their products are amazing. And I love working with that team. It's a beautiful team. They are putting on webinars twice a month, educational webinars, hosted by myself and Greg Menino, this amazing prosthetist. So, guys, if you're interested in just getting even more educational seminars on different topics and hearing from someone like Greg, who's a prosthetist and an amputee himself, check out the website. It's definitely worth the watch. And they do lots of free giveaways. Benny, what's going on? Still here, Benny. Still here. All right. Let's see who else is on board. We got Bonnie on board. All right. We got Brett Sykes. Hey, Brett, how you doing? Brett, you should be close to getting a leg, right? I think you were waiting on a leg. Let's see. Patrick on board. Oh, there's my PT right there. P&O referral was spot on. Oh, good. I'm glad that worked out. I know. He's a great guy, Patrick. I think you're going to have a great time working with him. I'm on your TV, Brett. Man, I should have put on better makeup then if I was going to be on your TV this evening. We got Rhonda on board drinking gin and tonic. Now that's a drink. We got Johnny V. Oh, Johnny V in the Cosi Talks house. We got Daryl on board. Diana from Riverview. Diana, I cannot wait to see what you think of the pants that you won. Diana was our big winner last week with Unitable, the adaptive clothing company. So they were lovely to donate a pair of pants, one of their Magnolia pants, very stylish. So Diana, I can't wait to see how you like them. How you doing, Kenny, man? I'm doing good. I am doing good. Let's see. Bob looks taller. Yes, this is my Bob Senior. I have several Bobs for those of you who are just kind of getting to know the show for the first time. This is the original Bob. There's a whole lot less of him than there was when we first started out this show. And my beautiful viewers have sent me Bobs over the past year, including a dog for Bob. This guy was sent to me from one of my viewers in Canada. So, hey, Angela, glad you could join us this evening. All right, guys, we got a nice little group going on, so I'm going to go ahead and get started. For those of you joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now for over 18 years. I have a private clinic here in Tampa that is exclusively for working with amputees. And obviously, this show right now. Hey, Chuck, good to see you, man. And guys, I am broadcasting to my YouTube channel as well as my Facebook channel. I'm kind of trying to get the word out about that because I know there's many folks that are not on Facebook or they just don't like using Facebook. So it's if you know of people in your support groups that have been curious about the show and they're not on Facebook, please encourage them to visit my YouTube channel. It's all under the same name, Cosi Talks. Really easy to find. Hey, how's it going, Jamar? How you doing, man? Hey, Glenda. So glad you could join us this evening. So, guys, I don't know if some of you guys checked out my post today. There are a couple of irons in the fire that I've had for Cosi Talks for the past almost a year now that I've been working on some of these really big projects. And I can't say exactly what these projects are. All I can say is it's basically the culmination of my 18 years as a physical therapist. It's kind of all coming together in this one big, ginormous project that I've been working on, and I cannot wait to share it with you all. I cannot wait to share it with you all. I am putting it together, working furiously to get all the bits and pieces put together and be able to present this to you all. And I need to stop talking because then I'm going to give away way too many of my secrets. Hey, Frank, compadre, how you doing, man? Oye, San Agustin, very nice. Hey, Jeffrey, how you doing, man? Robin, you made it, Robin. We've got Rebecca. Yes, it's very exciting, very exciting. And if some of you who are a little more tech savvy, you kind of zoom in on the picture I posted today, you might get a little bit of a hint as to what I'm working on. So that's all I'll leave you with that. So I'm excited. Okay, so let's go ahead and get started with some of these questions. So the first question comes from Steve, and this is actually a really nice, thoughtful question. Nobody's ever asked me this particular question before. Steve asks, Steve, where are you? I haven't heard from you. You always show up, Steve, and I haven't seen your name yet. So if you're there, you need to give me a shout out, man. No hiding in the background. Steve asks, so it's all come together and you've picked up your new leg and device from the prosthetist. What should you do with the device in the time that you're waiting to see the physical therapist? So that's kind of an interesting question, but there is one or two things that you can start doing. Okay. If you're new to using a prosthesis and you pick up your prosthesis from the leg guy or the leg gal, and it's about a week or two before you get to physical therapy, and obviously there's that like anticipation of wanting to start using your leg, but you don't want to just pop it on and go for a walk because you might end up getting hurt, right? Or developing some Robin's telling me to zip it. See, Robin knows me. She knows I got a big old mouth. I'm gonna zip it, Robin. I'm gonna zip it. So one of the things that you can work on is learning to don your prosthesis, learning how to put on your prosthesis. So hopefully when you picked up your prosthesis from the prosthetist, they probably gave you a rudimentary lesson. This is how you put your liner on. This is how you put socks on, if that's something that you're going to be using. This is how you thread the lanyard, for those of you using a lanyard suspension. This is how you use the pin lock, right? How you get the pin into the little lock. This is how you use the elevated vacuum, right? This is how you use the suction, et cetera, et cetera, et cetera. Like how to put your leg on. And that might sound like it's kind of like, well, duh, of course we can put our leg on. But believe it or not, that's actually a skill that I do work on with my patients in physical therapy. And it can be a little bit of a learning curve there, most especially with the liner, okay? These liners can be a bit tricky to put on, and it can require quite a bit of elbow grease, especially if the liner is fitting as well as it should, right? So with the liner specifically, learning to turn it inside out completely, learning how to put it on the bottom of your residual limb and position it correctly, and then practice rolling it up, okay? So just being able to put your liner on and off with ease, that's going to save you a lot of time in those beginning days when you're learning to use your prosthesis, because there's going to be a lot of on and off and on and off, okay, with the prosthesis. Learning the suspension, especially those of you who have pin lock systems. How many of you, Cosi poll, how many of you use a pin lock, right? And when you started learning how to use a pin lock, it took you forever to get the little pin to go into the lock? How many of you? I'm raising my hand because when I was a brand new therapist, trying to get that daggum little pin to go into that little hole in the lock system was beyond infuriating for me as a new therapist. I had so many times where I couldn't get the doggone thing to lock in place. How many of you had that problem with the pin locks? So that's one thing that you can start practicing. Thank you, Harsh. Thank you. I was feeling a little lonely there. What's up, comadre? Denise says me. So just practicing those things that it just needs repetition. And yes, Glenn, everything is a learning curve at the beginning, right? So that's one piece of the puzzle that you can start working on your own and doing that. Now, if you do not have particularly sensitive skin, okay, you've got relatively good skin, then you can kind of put yourself on a bit of a wearing schedule. And again, Your prosthetist should have already kind of started to prime you on some of this already. The physical therapist should be finishing this educational part, but the prosthetist should have kind of told you already, okay, wear it for the first 5 minutes of the day, wear it for 15 minutes a day, and start putting yourself on that schedule so that your skin can kind of slowly get used to wearing that prosthesis. And you can get used to just the feeling of that prosthetic device on your leg. Okay, and that usually can keep you busy for about a week or two before you go see the physical therapist. The next thing I would tell you is dust off that exercise program. Y'all know what I'm talking about, right? It's those papers that the PT gives you when you're in the hospital, and they got cute little pictures on it with exercises on it, and many of you just go and put it and use it as a coaster. Yeah, that's right. Talking to you, because I know that when I worked home health, I'd walk in the person's house and the home exercise program was buried underneath somewhere. So dust off that program. Start looking it over. If there's any of those exercises that you were given while you were in the hospital and you still remember those exercises, start doing them. Start doing them. You can get a little bit of a head start there and impress your physical therapist when you go in that first day. Johnny said it was an adjustment that the prosthetist had to adjust with the pin length. I know. Leslie! Ooh, Leslie. Ooh, guys, when I told you about one of the big projects and fun things that might be coming down the pike for Cosi Talks, it involves this lovely lady right here. And I'm putting her a little bit on the spot right now, but that's all I'm going to say. Not going to say anything else. All right. So, right. And guys, it's the pin lock. Yeah. Pin lock for me has always been my thing. All right, so let's move on to another question. We have a question here from Randy, okay? And if I have any prosthetists on board this evening, I would love to hear your input on this particular issue right here. Randy says, I have a very short 5-inch stump and I can't get a socket to stay on. I'm looking at a Martin Bionic socket. What are your thoughts? So here are my thoughts. I am familiar with adjustable socket technology, okay? The particular adjustable socket technology that I am most familiar with is the Limb Innovation socket. And unfortunately, they are a lot harder to find nowadays. I am not familiar with the Martin Bionics adjustable socket, okay? But if a person is having difficulty keeping the leg on because they have a very short residual limb, I don't think that the adjustability of the socket is what you should be looking at. Okay. What you should be looking at is the suspension, how the leg is held on. And a lot of times, and we did a show on this a couple of years back, and I think I'm overdue. I'm overdue to do a refresher course on sockets and just talk about all the different components of sockets. Okay. So guys, within your socket, you have the shape of the socket itself, right? You have the trim lines, meaning the edges of your socket, how far up or how far down. That's another component of your socket. And you have the suspension of the socket, meaning how it actually stays on your leg. And then you have the alignment, right? If the socket is set a little bit forward, if it's set a little bit back, if it's set out to the side, all of these things that go into your socket, right? And sometimes we get these components a little bit mixed up. So in the case of this gentleman, I think he's mixing up the tightness of the socket, the adjustability of the size with the suspension. Okay, so if you do have a very short residual limb, the suspension is what you want to really focus on with the fit of the socket. At least that's one of the many things you need to focus on, but that's what you need to talk about. So some of the, just off the cuff solutions that I've seen prosthetists use is obviously looking into see if elevated vacuum, if you are a candidate for an elevated vacuum system. Not everyone's a candidate and it doesn't work out for everybody, but that is an option to talk about. Suspension sleeves, okay? In a lot of my above the knee amputees, especially if they have a very short residual limb and they're particularly active, right? They might opt to have a TES sleeve, a test sleeve. Everybody pronounces it a little different, a belt. And it's a belt that goes around your waist and it just holds the prosthesis on. It gives it a little bit of extra suspension. The infamous pin lock, right? So I bashed the pin lock about 10 minutes ago, but now I'm going to sing its praises a little bit for people who do have shorter residual limbs where it's a little bit easier to keep that leg on with the pin lock. And those are just some of the basic options that you might have if you have a shorter residual limb. So let me just read through some of these comments and see if I missed anything here. Debbie says, I'm good at it now. Harsh says, adjustment with the rubber donut. Harsh, can you, oh, right, with the pin lock system. Thank you. Yes. There we go. All right, guys. So for those of you, if you guys don't mind putting this in the comment section, how many of you have somewhat short residual limbs, whether you're a below the knee or an above the knee amputee? And what kind of solutions did your prosthetists come up with to help solve this problem? Yes, Robin, the test belt does help to keep the prosthetic from pistoning up and down, meaning it prevents your leg from moving up and down within the socket. And it also does a really great job of controlling rotation. So for a lot of my amputee runners, my above the knee amputee runners, and also some of my bicyclists, they like to use that belt around the waist because it controls the socket from rotating on itself. Andrea, there's my OT. That's my occupational therapist. That's my peanut butter to my jelly. In rehab world, it's PT and OT all the time, all together. That's awesome. All right, guys. So if some of you have a short residual limb, put in the comment section. I want to hear from you. How did your prosthetist kind of troubleshoot that problem for you? I'm actually thinking of one of my very first patients in my clinic when I opened up my clinic in Tampa 3 years ago. She has an extremely short residual limb. She's a below the knee. She is almost a knee disarticulation. Very short little residual limb. And her prosthetist was just extremely skilled. And he would bring, I'm missing my bob that I need. Oh, hate it when that happens. I was going to show you guys. Hold that thought. I'm going to go get the other bob. All right. Here's the bob I needed. All right. So for my, excuse me, Bob. So for my below the knee amputee, okay, her prosthetist was very skilled at putting and hanging the prosthesis from her femoral condyle. So it's the part just above her knee and just made a very snug fit for her. And that kept the leg on really, really nicely. And then for her higher activity levels, when she would do yoga, when she would do running with me, then he had her in a pin lock system. That thing's gonna fall over. Oh no, it's falling over. The bobs are falling over. Okay, let's see. Doug says, just got the pin lock temporary sockets, making lots of adjustments. Important to put a sleeve on straight. Yes, and guys, that goes back to when you're learning how to put on your prosthesis, both your sleeve and the liner. If it's rotated, even just a couple of millimeters, it's going to affect the fit and how your prosthesis fits on you, and it can make it quite uncomfortable. So again, it's that, learning how to take the liner on and off several times and being comfortable doing that as you're learning how to use the leg. Rhonda says, yep, short limb below the knee. Charles says 9-inch stump as a below the knee. That's actually a pretty nice long residual limb there, Charles. We've got Harsh says, was fortunate to keep it a little longer with untreated fracture to give the cantilever effect. Patrick says, what about driving with the prosthesis? So that's a great question. I haven't talked about driving with prosthetic devices in a while. So when it comes to driving, usually the first thing I tell people is check with your state laws. Check with your local DMV, okay, and just find out, okay, what is the process of getting a license that shows that you either have adaptive controls or that you have been cleared to drive with your prosthesis. And I've seen the range of everything, guys. I've seen folks who have the full-on hand control system. I've seen people who have just very simple hand control systems. I've seen bilateral below the knees and bilateral above the knees drive the car without any kind of adaptation. Those are usually my amputees who have been amputees for a really, really long time. So I've seen everything across the board. The two biggest things is check with your DMV and check with your insurance company, okay? Because a lot of times people will try to kind of figure things out on their own, and God forbid they have an accident, right? And maybe the insurance then won't cover you if you've had the accident and you haven't declared it on your insurance that you are an adaptive driver. Now we're starting to see driving schools. So I know here in Tampa, there was one that one of my patients found where it's a driving school where they do the adaptations for your car and then they teach you how to use it, which to me is the best case scenario, because then you can take that back to your insurance company and show them that you are clear to drive with any adaptation, et cetera, et cetera, et cetera. So that's usually what I recommend is check with your insurance company, check with your driving department in your state. Let's see. Jeffrey says, been busy and great week. Push mowing in my stubbies is the greatest and worst workout ever. I saw that picture, Jeffrey. That was amazing. That is probably the best core workout and best workout for your glutes that you could even ever do. We've got Mervyn from Northern Ireland. Oh my goodness, Mervyn, you are the third person from Northern Ireland to watch the show. I am so excited when I see somebody from outside the United States. So thank you for staying up and watching. I appreciate that. Harsh says that he drives with his prosthesis as a right below the knee, and he uses it for acceleration without the ankle movement. Okay, let's see. So Damon is a short below the knee amputee, and he uses the supracondylar, meaning his prosthesis kind of hugs the top part of his knee and hangs on the condyles there to keep it suspended properly. Mark says he's a right below the knee and he uses the left foot accelerator. Ashley, random question. Girl, it's about time. You haven't posted a random question for me in a while. I was wondering what's going on, man. All right, so Ashley says, I've heard that sometimes if a person gets a prescription for a wheelchair for use at night or at times when they can't wear their prosthetic, it could cause insurance to deny prosthetics and prosthetic supplies in the future. Oh, yes. Is this happened? Has this happened? Yes, this has happened. I am by no means an insurance expert on how to get devices approved by insurance. It was quite honestly the least favorite part of my job when I worked in spinal cord rehab and when I worked in the rehab centers because it was frustrating. It was frustrating to know that my patients needed some of this equipment and the insurance would approve this, but it wouldn't approve that. So yes, I have heard of cases where a person will request a very simple wheelchair and it will be denied because the insurance paid for the prosthesis. So the insurance company's rationale is, well, if we're paying for your prosthesis, you should be using your prosthesis. If you can prove that it is medically necessary, and that's usually the key. And again, if I have any clinicians on here who would like to chime in on this, I would welcome their input. The key is medical necessity. That's what I have seen helps with folks. So one of the medical necessities of needing a wheelchair at nighttime is safety with balance, right? So the safety of being able to get into your wheelchair a lot faster than you can get into your prosthesis and then make it to the bathroom safely. The other thing to consider, Ashley, is if people are using a wheelchair just as a point A to point B, right? And sometimes they might request what I call one of the fancy wheelchairs, like one of the super duper sport wheelchairs, which can be much, much more expensive. So perhaps if the request is made for a bit more of a standard wheelchair, something a little more simple that doesn't need to be a sporty wheelchair, just needs to get you from point A to point B in the bathroom to the bedroom again, the insurance company might be more apt to approve of something like that. But again, the more supporting documentation that your providers can provide, the better chance at that. And that's another big thing is when I see that things are denied, it's because they were not requested properly in the first place, right? So if you know you're requesting something from your insurance company that your insurance company is going to be a little bit hesitant about, I would say try to get it right the first time with as much documentation as you can to support your claim. And if it doesn't work the first time, keep going back. Keep going back, okay? And keep trying. But yes, if there's anybody here who'd like to chime in on that one from the ONP community and physical therapy community, Andrea, if you got anything to add to that, I'd love to hear it. Doug says, I'm a bilateral below the knee. I understand the states might be different than Canada, but being aware that a driving test will most likely be asked. And yeah, and like I said, I had one patient that his job involved him back and forth in a car all day long. He was back and forth to different courthouses, client offices. So his car, and as he said, Uber was just getting too expensive. So for him, it was certainly worth the investment of paying for the course that would teach him how to use the adaptations, that would install it into his car, and that he could then present this certificate to his insurance company. Rhonda says, I drive the car after 2 weeks with my prosthesis, but my amputated leg is the left leg. Okay. Lisa asks, what is considered a short residual limb for a BK? There's no like specific measurements. Usually we just, as clinicians, I kind of just eyeball it and go, yeah, it's kind of a medium length. Usually I like, Lisa, what I see is how short is the residual limb compared to their intact, to the sound leg. So, if it's somebody whose original tibia was this long, right? And now their residual limb is this long, then I would say, okay, that's a pretty nice size residual limb compared to what they used to have. Obviously, when the shorter up you go. So I would say if it's 25% or less of what you originally had, that's kind of what I consider to be a short limb. But honestly, Lisa, it just matters more of how does it affect the person's function. There are some people, like I said, who've had very, very, very short residual limbs, and their prosthetists are wizards at fitting them with their sockets, and they're good. They're good to go. And then there's those that they have the short residual limb and they struggle just a little bit more with the fit of their socket. Let's see. Yeah, Patrick is another physical therapist on board. Thank you for joining, Patrick. And he says that the slippery slope is patient functional walker. So when you see someone who is, walking and using their prosthesis during the daytime, and they just need the wheelchair just to kind of, for those moments of the day when they need a break from their leg and they want to get from point A to point B. Yeah, it can be a little bit tougher. Hey, Jody from Vegas. All right. Justine, that's my other physical therapist assistant here on board this evening. And she says, as long as you stay on top and be persistent with insurance, sometimes it takes 3 denials before they approve simple equipment. And that's certainly the case. My first approach is, okay, do your best the first time to try to get all the supporting documentations and do it right the first time. But if you don't get it right the first time, keep going back. Guys, in my own breast cancer health crisis, there were several times where I had to go head to head with my insurance company. There was one particular, where I spent an entire year going after my insurance company to approve of a certain provider. And it was just time after time after time after time. And my thought was, well, the worst they're going to tell me is no again. So I'm just going to keep trying. That was my approach. Debbie says, I have a transportation wheelchair for at night, and I like the fact that it's smaller. And guys, I'll put this out there, and I don't normally like to do this, but if you use your common sense, then you can, there's a lot of really great refurbished wheelchairs that can be made available. Used wheelchairs, gently used wheelchairs. If you go to a lot of these mom and pop shops that have medical equipment, they have a section of refurbished wheelchairs. And if you find yourself with a refurbished wheelchair, take it to your clinician, take it to your prosthetist. Actually, you should take it to your physical therapist, where they can give it a once over and just make sure it's a safe wheelchair for you to use. And you can get some of this equipment for a lot less expensive in the event that your insurance company does deny it. Hey, Deborah, thanks for joining us for the first time from Houston. We've got Mariela on board. I am so glad to see you, Mariela. Let's see. Okay. Yeah. Patrick says specialists are up to date on justification better. And check with churches if you need a simple wheelchair. Sometimes they'll have those programs. Absolutely. Susan asks, where do you measure from to know how long your residual limb is? Okay. And like from the bottom of the knee. Okay. So when we measure leg length, and that's something that we do in general, there's a couple of different landmarks that clinicians might use, okay? So in a person who has a completely intact limb, we might measure the limb length from 2 different places. This little bone right here, it's the bone that when you put your hands on your hips, it's that little bone that sticks out into your hand. It's called the ASIS, that little part of your bone. And we will measure it sometimes into the middle part of your ankle. Okay. And there are other clinicians that do this measurement and they measure it to the outside part of your ankle, right? So that's typically how you do the measurement of the length of a limb. And depending on your clinician and what they're looking for will determine which one of those 2 measurements they will use, right? So if you are a below the knee amputee, you would start up here, right? And you would measure to the end of your residual limb. Okay. And the same thing with the above the knee. You would go from here to wherever your residual limb ends. And that's typically how it's measured. That's how I was taught to measure it. just to understand what a short limb is. And Susan, the short limb, medium limb, long limb, again, it's a comparison with your other leg, because there's somebody, for example, if somebody who is 5 feet 2 inches tall, their intact limb is already going to be a little bit shorter, but so it's all relative to what your height was to begin with, right? So it's just a comparison with the other leg. Let's see. Charles says, I picked up an Uber simple wheelchair from one of the community assistance agencies in my region. While I was volunteering for this agency, they comped me for the volunteer time with the wheelchair. And I keep it around the house for the closet for when I do need it. And that's usually how it works. Let's see. Yeah, so Ashley says, I've been lucky. My insurance has approved everything I have asked for so far, but I've never had to worry about denials, but my friend has been denied. It's frustrating. Guys, it is kind of my hope sometime in the future to bring on, there are definitely a couple of experts in our community that they know how to get insurance to approve of those devices that you need. And they have certainly a lot of advice and wisdom that they can give. I am not one of those people, but I am hoping that sometime this year we can get one of those folks on board. Let's see. Yeah, Debbie says, my boyfriend got mine secondhand. Kelly says, I have a wheelchair that needs repair. Where do I take it to get it fixed? Anybody know? So Kelly, if it's simple repairs, physical therapists, we usually have an Allen wrench and a screwdriver hanging around in our clinic, and we can make very simple repairs. Prosthetists, same thing. They have lots of fun toys in their clinic, and they can also usually make very simple repairs. Other thing I would do, Kelly, if this is a wheelchair that you got directly from the manufacturer, call the 1-800 number. There's going to be a sticker somewhere on that wheelchair with a 1-800 number, and ask them, where can I get my wheelchair fixed that I bought from you? Okay. If it's a wheelchair that you got a really long time ago or a secondhand wheelchair, go to your local medical device store. So I know we have one here in town, and it's a mom and pop pharmacy and medical device store. And that's honestly where I send all of my local patients to go get things fixed, like getting the rubber stoppers on the bottom of the walker, to get screws tightened and things like that on their wheelchair, or to repair little minor repairs like that. Okay, so Bonnie, really great question. Debbie says, I live in St. Petersburg, and Disability Achievement Center does so much. Debbie, I would love to have the information for that, because that's a place local to me. So Debbie, can I ask you to please email me on my Facebook and just email me their contact information? I'd love to have that as a local resource. Let's see. Bonnie says, I was told by an occupational therapist that there is a difference between a standard wheelchair and an amputee wheelchair. What's the difference? And yes, that was actually a question on one of my tests in school, so I actually remember that one. It's actually for a bilateral amputee. So when you have someone who's a bilateral amputee, specifically a bilateral above the knee amputee, they obviously don't have the weight of their legs to help balance the wheelchair. Okay. So if they're not careful, they're going to tip their wheelchair and they're going to fall out of their wheelchair. So the basic difference between a standard wheelchair and an amputee wheelchair is that the axis of the wheels are set further. I think it's like 2 inches further back to prevent the wheelchair from tipping. And that's usually only the case, again, for someone who's a bilateral above the knee. With unilateral amputations, the weight of the sound leg is enough to prevent the wheelchair from tipping. That's the biggest difference. And then honestly, wheelchairs, again, I worked many moons in the spinal cord rehab center in Dallas. And, wheelchairs are just as unique as prosthetic devices. There are so many different features and bells and whistles that can be put onto a wheelchair to accommodate it for the person's needs, okay? And again, just like anything else, the more bells and whistles you put on there, the more expensive it's going to get, and the more the insurance is not going to want to pay for it. So just putting it out there. Deborah says, FYI, you can get rubber ends for walkers and wheels at Walmart. Very true, very true. I like to support my local business, so whenever I can, I try to send folks to the mom and pop pharmacy. So, but yes, you can get these items at Walmart or on Amazon. All right, let me grab another question from here. Ooh, this was a good one. This one was a good one. Okay. So Jane says, I am an above the knee and I am having problems with my residual limb. Has anyone experienced their limb going numb or icy hot feeling in it? My residual limb feels like it's on fire and then an icy hot feeling, and then it also feels like it's asleep. I do experience phantom pain and real pain in my limb. What kind of doctor do I need to see? Okay, a lot of stuff going on here. A lot of good stuff though. First of all, what I liked about Jane is that she understands the difference between phantom pain and pain in her residual limb. Okay, so just as a quick recap, I've done a couple of shows on this, guys, and guys, you can actually go to my YouTube channel. I'm gonna type that in real quick. I'm gonna give myself a little bit of a plug. Why not? My show. Okay, so if you haven't already been to my YouTube channel, there's the link. Right click on it and subscribe to it, guys. Trying to build that up because we're going to do some really exciting things with the YouTube channel. So go join that right now. But in the YouTube channel, you'll also find some shows that I've done on phantom pain and residual limb pain. As a quick recap, phantom pain is pain that is felt in the foot or the leg that is no longer there. Okay, so you are feeling pain, crushing pain, burning pain, stabbing pain, electrical pain in your foot, in your calf muscle, and that part of your leg is not there. Versus residual limb pain, which is actual pain in the limb that is still there. Why do I take the time to explain this a lot? Because it's important to identify the difference between the two, because how you treat the two is very different. Okay. So in Jane's case, it looks like she's having both. And this is a very common thing. Sometimes you have a person who exhibits residual limb pain and phantom pain. And then it's up to the clinician to figure out, okay, well, is the residual limb pain triggering the phantom pain, or is the phantom pain triggered on its own? Trying to find the triggers to the phantom pain. Okay. The fact that she's having a lot of these hot, icy cold, and numb feelings in her residual limb makes me think two things. Number one, nerve. Okay. If she has a neuroma that's forming, that's a little bit of a balled up scar tissue at the end of your nerve that can really get you hot and bothered and cause some problems. Okay. Vascular. That's another one I'd be wondering, if Jane lost her limb due to vascular issues, okay, those vascular issues are still present and ongoing in her body. Okay, so Jane, in this case, if you're listening, I would recommend, number one, the kind of doctor you want to see typically is your PM&R doctor, your physical medicine and rehabilitation doctor. That's the doctor who took care of you while you were in the inpatient rehab unit. And the reason why they're my favorite kind of doctor to send amputees to is because they're the ones who work the most with amputees in terms of doctor world, right? So once your surgeon discharges you, the surgeon who did your amputation, that's it, they're done, right? The PM&R doctor for many of you will be the one who continues to follow you. How many of you here are how many of you here are being followed by a PM&R doctor? Raise of hands, show of hands. Show of hands. Susan says, usually phantom pain is electrical, residual limb pain is pins and needles and burning for me anyhow. And actually, Susan, that is completely different for everybody I've seen. The phantom limb pain can present with so many different kinds of sensations. When it's residual limb pain, when I think of pins and needles and burning, to me, that's very specific to like a neuroma type pain. So Megan says she's still being followed by her PM&R doctor. Johnny's being followed by his PM&R doctor. So, when you're having problems that are related to your limb, that's typically the first person I would go to. Now, if you are someone who has a known history with vascular issues, right, and you're being followed by a vascular doctor, that's the person I would go see first, right, just to make sure that there's nothing going on. And I have a patient right now. I had to send him back to the vascular doctor because he's starting to present with certain symptoms in his sound leg. And I want to make sure that that leg is still okay from a vascular standpoint. So Ashley's still being followed by PM&R. Brett is not being followed by PM&R. Okay. Now, as always, guys, when you have any of these problems, go see a doctor. Okay. Even if it's your primary doctor may not be as familiar with some of these issues that affect amputees, but you can request from your primary doctor, hey, can you please give me the referral to a PM&R doctor? Okay, and you can make that request yourself, right? Mariella says, after the COVID-19 vaccine, my residual and phantom pain have increased. And yeah, I've heard some similar things from other folks in the community as well. Okay. All right, I got one more question, and that one's on my phone. I got like 40 million notes over here. All right, this one is from Kay. And okay, here. Let's see. Susan says, I go to a team every 6 months at rehab hospital, head of amputee specialist, nurse, physical therapist, and prosthetist. And that is the perfect solution. Andrea says, or neurologist. This could be a spinal impingement issue, but PM&R is a good start. Yes, absolutely right, Andrea. And again, when you have that burning sensation or the leg going numb, icy hot, again, it's either neurological, something with one of the nerves that's tickling and going wrong, or something with vascular. There's something there. And it could be, guys, that there's something with the fit of the socket itself that is triggering these issues. So again, when you're having these issues and it's kind of your first time experiencing them, don't just dismiss it. Don't just say, oh, this is just part of me, because I see that in a lot of folks that they just like, well, I had an amputation. This is just how I have to live it and deal with it and suck it up and deal with it. No, if you're experiencing these symptoms, especially if it's the first time that you're feeling these things, get it checked out. Okay, it could very well be that, yes, this is how your phantom limb pain presents, and they can try treatments with that, but it could be that there's something else underlying going there. Okay, let's see, Rebecca. Okay, so this question from Kay, she asks, how often do people take their leg and liner off during the day? Mine feels better in the morning, but a few hours later, after getting in and out of the car or using the unstop to sit down bike, it gets loose and can be embarrassing as I try to readjust. I've had my leg a year, but had revision surgery in November, so I had to stay off my leg for 2 months. Now I'm on my third socket. I know that my leg will probably shrink more and I can get it on easier in the morning, but wonder if several ins and outs of the cars, I have to do a lot of adjusting. Okay, so it's basically, is it normal for folks to have to do a lot of adjustments to their leg throughout the day? Yeah. It's actually not very common that I hear someone tell me, oh, I put my leg on in the morning, I go about my day, I don't think about it, and I take my leg off at night when it's time to go to bed. Unfortunately, I don't hear that as much. Usually I do hear a lot of, especially here in Florida, where it's a lot of sweat, a lot of hot weather. Sometime throughout the day, I have to take my leg off. I have to wipe things down. I have to add socks. I have to take socks off. And then certainly, Kay, you had a revision in November and you were off your leg for 2 months. So you've only had your leg back for a couple of months. So you're definitely going to be having volume changes in your residual limb. Okay. And certainly as your day goes on, your limb will tend to shrink a little bit and you're going to have to make those adjustments. Hopefully, like I said, usually many of you who've heard me talk about this on the show, for many of you, 1.5 years after your final surgery. So those of you who have had revisions, you start the counting after your final surgery. Hopefully you start to see a little bit of a plateau in your limb expanding and shrinking throughout the day, and it gets a little bit more steady. Susan says, I'm in an elevated vacuum suspension and I never have to take off or add or remove socks. And again, elevated vacuum suspension systems are a wonderful tool. I've heard a lot of people who have them that they love it. They feel their volume is more controlled throughout the day and they feel more connected to their leg. That's definitely something I hear a lot, especially from very, very active amputees, that when they do their sports and biking and running, that they feel much more connected when they have an elevated vacuum. Now, something to be said about elevated vacuum is you have to know how to use it. And I've seen some people that they did not use it properly and they ended up getting skin breakdown and blistering and things like that. So as with any equipment, the higher the technology of the equipment that you add to your prosthesis, more things that you need to be aware of and be able to keep track of. Okay, so and again, conversations with your prosthetist to determine, is this really the right option for you? Okay, so have those conversations. Let's see, Johnny says, I only take my leg off to wick perspiration or reset my liner on my residual limb. Jody says, I take it off 3 to 4 times a day and readjust and wipe down, right? Daniel says, I'm lucky and I haven't had to add any socks in a year, but I have to take my leg. Whoops, that comment's just disappeared. Wait, where'd you go? But I have to take my leg and clean it a few times a day when I'm really active, okay? Yes, Susan, you are very lucky. You've never had a blister or a skin breakdown, so you are very lucky. And that means you know how to use it properly. That means you know how to use it well. Dan says, oh, you've had the TMNR surgery and how it's helped. Excellent. No, Dan, thank you so much for sharing that with us. So Dan just shared that he had TMR surgery, which is targeted muscle reinnervation. And I'm so glad you brought that up, Dan. So targeted muscle reinnervation, we did a show a little while back on it, and I had the wonderful Dr. Leonard Dedesi, orthopedic surgeon, come onto the show, and he shared, because he does a lot of those surgeries himself. So we talked about the procedure itself, and basically, just long and short, when an amputation is done, the surgeon will take the nerve, transect it, cut it, and then allow it to retract back into the tissues, almost like a rubber band, like, right? It goes right back into those tissues. So what happens, unfortunately, especially if it's a sensory nerve, right? The ball of scar tissue forms around the end of that nerve, and it can start, causing problems and pain and problems, right? So with TMNR, targeted muscle reinnervation, and this was a surgical technique that started happening actually almost 20 years ago. They take the nerve ending and essentially plug it back into some of the muscles that are left, right? So they're basically giving the nerve work to do. Idle hands make devil's work. So if that nerve is left flip-flopping around in that soft tissue, it's going to cause problems. If you put that nerve to work, the idea is that it will cause less problems, right? And then there's really more exciting applications to TMR. It was originally developed for the upper extremity amputees, that they would take those nerves and plug them back into the muscles so that the individual could operate one of those myoelectric, those mind-controlled upper extremity prosthetic devices, which is really, really, really cool. So the exciting thing is we're going to have Dr. Dedesi back on the show in July. It's in my calendar. I know when he's coming. It's in my calendar. So he's going to be coming back on the show in July, and we're going to talk more about TMR and also RPNI, which is a kind of slightly different version of the TMR surgery. So put that on your calendars, guys. So Dick Dever says, I wear my leg 14 to 16 hours each day with no adjustments. You are one of the minority, Dick Devers, and congratulations. It's kind of awesome. Charles says, since I've changed to an elevated vacuum system, I have had no issues that I cannot easily adjust during each day, which is good. Let's see. Susan asks, do you recommend the operation where they fuse the two bones together like a bridge, or no? What you're referring to, Susan, is the Irl procedure. And let's see if Bob is willing to cooperate one more time to demonstrate for us tonight. So the Irl procedure, typically when you do an amputation, right? If it's an above the knee, you cut through the bone and then they bevel it and they might shape it just a little bit at the end. And below the knee, they cut through the two bones. They will cut through the fibula, which is this little tiny outer bone, and they will cut through the tibia, which is the big fat bone, right? Your shin bone, right? And then the two bones are just kind of left there, right? So when you have those kind of amputations, you are not able to put weight onto the end of your bone. Okay, many people have that misconception. They think that at the end of their bone, they can put weight on it, but they can't. This part of the bone where it gets transected and this part of the bone was not meant to take the weight of your body, right? So your socket, the whole purpose of your socket is to take the pressure away from that area. Now, the Irl procedure, and it's spelled ERTL, And guys, I'm just giving you the basics of information on the Irl procedure. I am not an expert on it. Just I know just enough to get myself into trouble. I believe it was developed by a Dr. Irl. Okay, and what he did was when they transect across here, right? They take a little bit of a bone graft, and I'm assuming they probably take it from the hip. That's usually where they take bone grafts. And then they create a little bony bridge, right? So it connects these two bones together and it has to heal, right? And the goal with that is that the individual is able to put weight on the end of their residual limb, that they're able to do weight bearing in their socket with that residual limb. Okay. And there's a few other benefits. I need to really dust off my knowledge on the Irl, but that's kind of like the basic gist of it. I've had some people that they had great results and they like it. And then I've had some people that it didn't necessarily, um, it was no different than had they gotten a traditional amputation. Okay. Let's see. Mariella says, I adjust mine at least 3 times a day between 7 and 9 ply. Yeah, and here in Florida, like I said, with the sweat that we have, people dramatically will change volume. And even other parts of the country, just with summer coming on board, that's going to happen too. All right, guys, so I am going to do one final plug, and I ask you to bear with me on this one, please. Okay, I put the link up once again to my YouTube channel, guys. I am a mom. I call myself a mom and pop organization. It's myself and my couple people members on my team, and we work so hard to produce this show. But I love your help. I love those of you. Thank you so much for those of you who take my posts and share them to your support groups. Those of you who tag people to watch my show, whenever you tag me to answer a question, thank you so much. If tonight I can trespass upon your goodwill, and to please visit my YouTube channel and hit subscribe if you haven't already done so. I've been adding new tidbits to the YouTube channel lately. So if you wouldn't mind sharing that and sharing that to your communities, I would greatly appreciate it. So guys, for those of you who are new to the show, you can reach me on Facebook, you can reach me on Instagram, you can reach me at my website at www, and I'll put that up there too, .cositalks.com. Okay, so you can reach me through all of these arenas. Please feel free to send me your questions. I answer every single question that I receive. Okay, and if I missed your question tonight, definitely send it to me so I can answer it for you on next week's Same Bat Time, Same Bat Channel show. All right, guys, I'm going to go ahead and sign off. Thank you so much, guys, for joining me and for allowing me to be a part of your lives this evening. I will see you all next